All right, and we'll get started there, and then everybody, you're welcome to chat in your questions or wait until the end. Well, if I can find it.
Okay, so I don't mind getting interrupted in the middle if anybody has a question along the way. So please don't worry, just somehow or other indicate that you have a question and I'm happy to answer it. So the title, when you look at the echo, says goiter. And that, just for clarification, that doesn't really mean anything in particular. It's kind of a word that insurance companies will accept to pay for thyroid ultrasounds and things like that. You've probably seen that for different people, the word goiter means a different thing for every individual. Like somebody will say, oh, I had a giant goiter, and they mean their thyroid was enlarged overall. And other people will say, oh, my grandmother had goiters on her thyroid gland, and they mean nodules. So what that means really varies. It's just an old-fashioned word for technically something that isn't a 100% completely normal size, shape, everything about a thyroid gland. So a normally sized thyroid that has one little nodule on it can be called a uninodular goiter. A really large thyroid that has no lumps or bumps can be called a goiter. So it's, again, just a very vague word, and you can use it, and insurance will cover an ultrasound if you use it, but it doesn't mean anything in particular unless you clarify with like uninodular or multinodular kind of terms. So next slide, please. Today we'll just talk a little bit about epidemiology of thyroid nodules, how to evaluate them, and then what labs and imaging we do and how we further evaluate nodules with suspicious findings, etc. Next slide, next slide. So thyroid nodules, I tell people if I took an ultrasound machine up and down the sidewalk, 1 out of about every 3 people has one or many nodules on their thyroid gland. And the vast majority of these are completely benign things. So I tell people about 95% of all thyroid nodules, whether they're big or little, are benign things, like freckles on our skin. They're not melanoma, they're just freckles. And you can have thyroid nodules whether your thyroid blood tests look normal, abnormal. It doesn't really predict anything based on what your thyroid blood tests show regarding thyroid nodules. Next slide. So how do we find them? Next slide. Technically, really, we should only be finding thyroid nodules based on physical exam. We shouldn't just send people for ultrasounds simply as a baseline evaluation of their thyroid function. It really should be limited to if you feel something on your exam, because we're really overdiagnosing and causing a lot of anxiety about thyroid nodules, which again are usually benign things. So if you may find them on exam, they may be found incidentally when people are doing their health fair screenings, because a lot of those offer carotid Dopplers. And if they have a CT of their chest for some other reason, sometimes it shows the thyroid and it may comment on nodules. So we can find them incidentally or on exam. Next. So this picture you can actually see. Sometimes if this is a really soft nodule and you palpate this, it might squish in and you would say, oh, I don't feel anything, so it's not a nodule. But it could be fluid filled, it could be posterior and kind of just pushing the thyroid forward. So I would describe this in my exam, in my note, as a visible something centimeter nodule, and I would have them swallow and I would see it go up and down, and then I'd feel it and try and describe what I feel. But it could be very soft and squishy. Hopefully it's not hard and fixed, and it can move with swallowing. Next slide. So here's a case, a healthy patient. She's a 42-year-old woman, and she's just in clinic for an annual checkup. And you feel her thyroid or her neck, and you feel a thyroid nodule. Next. So I would ask her, has she herself noticed it before? Maybe because this is my first visit with her, she's already had this evaluated. Maybe she has previous ultrasounds. I'd ask her, has it changed at all? Has she noticed any changes in her voice or any unusual cough? Has she had any trouble swallowing? Or if she lies down flat on her back at night, is she having trouble breathing? I'd ask about a family history of thyroid cancer, and I'd ask about radiation exposure. Next. So as part of the exam, I would also have this person put her, in this picture, it's obviously not a her, but put their arms up over their, as close to their ears as they can. And if their face turns bright red, that's called a positive Pemberton sign. And that's an indication that whatever their thyroid is doing, if it looks enlarged, I would have them do this Pemberton thing. And if their face turns red, that's an indication that this thyroid gland is too big for that thoracic area and neck area and is blocking blood flow to the head. So that would all, right off the bat, be an indication for surgery of getting the thyroid debulked or just out of there. So I'm not going to go into this part really any beyond that, but this is something that I do during my physical exam just to make sure that a thyroid I see or feel isn't so enlarged that it's causing vascular obstruction. Next slide. Next slide. Okay, so, oh, sorry, next slide again. So what do we do next when we have felt a thyroid nodule on our exam? First, I'm going to say what we should not do, because something that we often do is wrong, and I never learned this till I was a fellow, and so I try to spread the word to as many people as I can what we shouldn't be doing when we just happen to feel a thyroid nodule on exam. Next slide. Please do not order a thyroid uptake and scan simply because you find a nodule on your exam or they came in with a chest CT showing a thyroid nodule. Don't order a thyroid uptake and scan, okay? That is not the best way to look at a thyroid nodule at all. I'll explain when we look at it in a second, but this is not the first step in evaluating a thyroid nodule and is extremely unlikely ever to be something that we need to order for anyone with any thyroid nodules. Next slide. Okay, next slide. All right, so we think of thyroid uptake and scan as having one purpose ever, and that's to see why someone has hyperthyroidism. That means what? It means we have to know what their thyroid blood test shows. So if they have a thyroid nodule, you do not order a thyroid scan unless you already know that their hormone levels are in the hyperthyroid range, okay? Next slide. So what do we do? Next slide. Blood tests, because again, we have to know, are they hyperthyroid? So we do a TSH level, and if the TSH is suppressed, then they are hyperthyroid. And if you have felt a nodule and their blood tests show that they're hyperthyroid, then the next step is going to be a thyroid uptake and scan to see if that nodule is hot. Next slide. Okay. The reason that you do the thyroid uptake and scan is because the area that is making too much thyroid hormone could be the whole thyroid. Even if they have a nodule, the whole thyroid could be overproducing thyroid hormone, and the thyroid uptake and scan will show that, and that would be consistent with Graves' disease. The patient could have thyroiditis, which is when the thyroid kind of just coughed out a bunch of thyroid hormone a couple of weeks ago. It's still circulating around in the body, but the thyroid itself is no longer actively producing thyroid hormone, and it may still just incidentally have a thyroid nodule. So the thyroid uptake and scan will explain that this is thyroiditis. Or this thyroid uptake and scan could show that this nodule that you feel is looking hot on the uptake and scan. It's showing a lot of uptake. And that would indicate that that nodule is a hot nodule overproducing thyroid hormone. And then you know that you don't have to worry about it really doing anything except for its function. So the thyroid uptake and scan is only done when you already know a TSH is indicating hyperthyroidism, so that you know why that person is hyperthyroid. Is it Graves'? Is it thyroiditis that'll get better on its own? or is it a hot nodule that you can burn out as a treatment later? Other than that, there is no indication to do that thyroid uptake and scan simply to look at the nodule to see if it's hot or cold. Your only question is, why are they hyperthyroid? Your scan will answer that. Beyond that, don't do the scan, please. Next slide. Okay, so this is just a summary of saying what I was just saying. So if the nodule does not look suspicious in some way, but you won't know that till you've done the ultrasound, which I'll talk about in a second. And so again, this is just saying if it's hot, you'll see that on the scan. Other than that, don't worry about the scan. Next slide. Okay, so if their TSH is normal or hypothyroid range, meaning a high TSH, then, next slide, your best picture is going to be, next slide, just doing an ultrasound. An ultrasound is hands down the absolute best way to look at a thyroid gland overall and to look at and evaluate thyroid nodules. They can get down to millimeter cross sections and will tell you all about the makeup of a nodule, whether it's suspicious or not, how big it is, etc. Next slide. Okay, next slide. Okay, so when we have our ultrasound of the thyroid to evaluate this nodule, we're going to want to know about how big the nodules are and what the nodules look like in terms of their characteristics. Next slide. Okay, so for size, we have 4 different cutoffs, and you don't have to memorize any of these things ever. They're in all of the endocrine guidelines. And everything that is going to come up in these slides is based on the American Thyroid Association guidelines from 2015 on evaluation of thyroid nodules. So that is a really easy source and resource to look up, and it comes with the pictures that'll come up in the next couple of slides as well. All right, next slide. So if a nodule that you see on an ultrasound in someone who is euthyroid or hypothyroid, if the size of the nodule is less than 1 centimeter, you don't do anything about it. This does not mean that there may not be thyroid cancer in that little tiny thyroid nodule. Thyroid cancer is the only thing we care about in thyroid nodules, and thyroid cancer does not discriminate in terms of what size nodule it will grow in. You can have a 4 centimeter nodule that does not have cancer. You can have a ½ centimeter nodule that does have cancer. But if a nodule is less than 1 centimeter, we don't do anything about it, even though there could be thyroid cancer in it, because it is not going to be clinically significant to the patient in any way, and we can just monitor it over time rather than making them worry that they have thyroid cancer, making them get a total thyroidectomy for something that will never kill them and risk hypocalcemia if all their parathyroids get ripped out from that surgery. So under 1 centimeter, we would only follow it with a repeat ultrasound in about a year. If a nodule is greater than 1 centimeter or 1½ centimeters, 2 or 4 centimeters, the next slides will go into the details about these. Next slide, please. Okay, next slide. So if a nodule is 1 centimeter and has high suspicion or moderate suspicion findings on the ultrasound, we will biopsy it. Next slide. So here is a picture that comes from the American Thyroid Association guidelines. Again, we have this printed out and posted on our walls here in our clinic, and whenever we get ultrasound reports, we look at the pictures themselves and we compare those pictures to this little piece of paper that's on our wall. So in the top line, the high suspicion for thyroid cancer, if nodules look like anything along that top line, that nodule has a 70 to 90% chance of having thyroid cancer in it. And so we would want to evaluate that with a biopsy. The next line down on that very same page shows intermediate suspicion, and nodules that look like this have a 10 to 20% chance of having thyroid cancer. So with these high rates of possible thyroid cancer, we would stick a needle into these nodules when they're really still pretty small, only 1 centimeter or bigger. We would definitely biopsy these. So again, along the top row, you'd see things that look like calcifications. That's those bright spots. In the, let's see, the fourth one from the left on the top row, you can see that that is a hypoechoic nodule, meaning blacker or darker gray than the surrounding area. And it also looks like it's kind of sticking up through the capsule of the thyroid gland. And it looks like it is kind of what we say taller rather than wide. So it has a more up and down shape, bigger than the sideways shape. Things like that are all considered high risk. So we would biopsy a nodule, even if it's only 1 centimeter, if it looks like any of these things. So we can make sure that there is no thyroid cancer in it, or if there is, we would, send them for surgery. Next slide. Okay, so what if it is a low suspicion or very low suspicion type of description for the thyroid nodules that you see? Next slide. Next slide, please. So looking at the third down row and the fourth down row, these are the way nodules look that are usually benign. Only 5 to 10% chance of thyroid cancer, or even less than 5% chance on that very low suspicion. So if, on the second line from the bottom on the left, you see something that looks almost like a sponge, like you could kind of squish it down and water would shoot out, that's spongiform. That is a very common way for thyroid nodules to look, and that is a very benign sort of thing. Therefore, this is a nodule that, if you go to the next slide, we wouldn't biopsy until it's bigger. So for the low suspicion ones, we would wait until that nodule is 1.5 centimeters or bigger. Or for that spongiform type of shape, we would wait till it's 2 centimeters or bigger before we would biopsy it. And again, it is not because a nodule of this size can't have thyroid cancer in it. It's just that it's much less likely, and we don't need to go searching for things that are unlikely to hurt the person, because even the evaluation can be anxiety provoking. It can be harmful in terms of treatment that's done unnecessarily. So we use caution in terms of our evaluation. Next slide. Okay, that bottom one, I think the next slide, we go to that next slide. The very bottom one is a pure cyst. It's just black. It's filled with just plain old fluid. Think of it almost like a little blister inside of your thyroid. It is not going to have any problems with it. As long as it's not really big where it's choking the person, you can just leave it and never look at it again. Next slide. Okay, what if a nodule is greater than 4 centimeters? Again, that does not increase the chance of cancer in that nodule, because thyroid cancer doesn't care how big a nodule is. But we do want to biopsy it, and we want to consider surgery even if that biopsy comes back benign, simply because of false negatives. If you imagine a 1.5 centimeter nodule diameter, and you stick a little needle into it 4 or 5 times, you're going to sample a good chunk of that little tiny nodule. But if you have a nodule that's 4 centimeters or bigger in diameter, and you stick a little tiny needle into it 4 times, there is a good chunk of that thyroid nodule that you're missing by doing that little FNA, fine needle aspiration. And so because of sampling error, you could be missing thyroid cancer. So the guidelines say, consider having half the thyroid with that big nodule in it removed, even if the biopsy is negative, because of a concern that thyroid cancer is in there and hiding. And of course, if the biopsy shows that there is cancer in there, then it doesn't matter how big the nodule is. You happen to sample it when you did that biopsy, and so then you would go on to treat for thyroid cancer. Next slide. So if you haven't ever had a thyroid biopsy or seen them, I try to explain what the process is to patients before I send them for one, just so that they know what's going to happen. And I explained to them that they are going to go to the same place where they had the ultrasound done. They can drive themselves there and drive themselves home. There's no anesthesia that's going to make them sleepy or anything. And then they lie on the table just like they're getting an ultrasound, and they get their necks cleaned off with betadine and alcohol. And then usually 4 or 5 times using an extremely tiny needle, that's why it's called a fine needle aspiration. They go right, sometimes they also numb the skin with lidocaine, and then they go right through the skin into the thyroid nodule using an ultrasound to see where the nodule is. And then they suck out a few cells, pull the little needle out, put those on a slide. Each needle is in for, 10 seconds, 20 seconds while they just suck out a few cells or less. And then they do the next little biopsy, trying to get a little area that they didn't hit the first time. And again, like 4 times or so, and then the patient can sit up and go home. And then we get the results. Next slide. So here's a picture of somebody getting one. Next slide. Okay, so here's another case. A 55-year-old man has multiple nodules on his ultrasound, and 6 of the nodules are greater than 2 centimeters in size. Next slide. So which ones are we going to biopsy? Because in the old days, we used to say, just biopsy the dominant nodule, meaning the largest nodule. But again, remember, size doesn't indicate risk of cancer. Next slide. We need to think about which of those nodules has the scary characteristics so that we can tell the person who's going to do the biopsy specifically which nodules we want biopsy. Next slide. So for example, if 6 of those nodules is bigger than 2 centimeters, one of them looks like a sponge, and 2 of them have calcifications, but they are 2 centimeters. The spongiform one is 3.5 centimeters, but the calcification ones are 2.2 centimeters. You would want to write in your request for the biopsy, the FNA, please biopsy the right upper lobe 2.2 centimeter nodule that has calcifications. Just be specific, and the person doing the FNA will easily know exactly what you're talking about, because radiologists have these criteria as well. They know exactly what you're talking about, and they know how to find the nodules because they made the initial report in the first place saying there is a right upper lobe nodule that has calcification. So they know what you're talking about, and they'll be happy to have it decided for them which nodules to biopsy. Next slide. Okay, so again, don't just choose the dominant biggest nodule, because you could easily miss a thyroid cancer that just happens to be in a smaller nodule. Next slide. Okay, so what results can you get back from a thyroid biopsy? These are the results. Benign, which then you would only need to follow once in a while with an ultrasound. Some of the older endocrinologists never follow with any repeat ultrasounds because a negative FNA result is usually very, very accurate. But because of a risk of false negatives, I would usually follow up with an ultrasound in about a year, make sure that nodule has not changed, and then I would probably just follow with palpation over time and rebiopsy, re-ultrasound only if it changes on exam after that. You may get back results from your biopsy that are described as insufficient. So that means that even though they're there, they see with the ultrasound that they are in the nodule when they're doing the biopsy. The cells that come back may have not enough cells to make any decisions, and therefore you have to repeat the biopsy in about 3 months or so. Another option that could come back is something called suspicious or atypical or things like that. And so then I would suggest that you send people up here for that kind of thing, but you certainly can manage it yourselves where you are. If it's suspicious, you send them for at least a hemithyroidectomy. If it's atypical or a follicular neoplasm kind of thing, there are also genetic tests. We call them AFIRMA, AFIRMA testing, that looks for genetic mutations in the sampling that was done by the biopsy. that would help you know if in fact the suspicious or atypical rather is actually fine, low risk, in which case you just follow with repeat ultrasound over time to make sure it doesn't change, versus truly suspicious or in fact overtly thyroid cancer, in which case you would send them to the surgeon. And then there's a result that could come back from your biopsy that just clearly states thyroid cancer is present, and then you would refer to us or to surgery. There's good data, this is not at all to toot Endocrine's horn, but there's good data to say that if people in fact have thyroid cancer, that their prognosis over time and their survival rates are better if they are in fact followed over time by endocrinologists. So I'm happy to give advice if patients can't get here, so everyone out there can manage these patients all by themselves, but that data does exist. So next slide. Okay, so another reason to consider sending to us, or at least call us. I mean, we're always happy to answer questions like e-consults, or even just over the phone, you call the Mars line so you can manage people where you are. So if they have thyroid cancer, again, the American Thyroid Association guidelines are very clear about what to do. So anyone can follow those guidelines and that won't lead you astray. If people are pregnant and they need thyroid surgery, then any surgeries should be done during second trimester. If they have thyroid nodules that have thyroid cancer in them, the chances of that cancer ever doing anything bad to them or growing quickly during pregnancy during 9 months is so small that we rarely would send anybody for surgery, even during the second trimester. We just follow them. And then when they're done with the pregnancy, done nursing, etc., then we would really address it in a better way. But usually thyroid cancer is extremely slow growing. It usually, if it's treated properly, has near 100% survival rates at 5 years and even up to 10 years. So thyroid cancer is not something we typically have to be too aggressive about. So if somebody's pregnant, we don't have to freak them out about getting surgery most of the time. If the biopsy shows that follicular neoplasm or Hürthle cell neoplasm are atypical, consider doing that Afirma genetic testing, or you can do a hemithyroidectomy to take that out so that the pathologist can really decide if it's benign or cancer. And if you're just not sure, then call us, and we're happy to tell you over the phone or through my chart what you should do with anybody. And if you are going to send people here and you have an ultrasound report, it really helps for us to have that in our hands when we see the patient, just like it will help you if you're looking at the patient too. Next slide. Okay, so just as a summary, thyroid nodules are extremely common. We do, as the very first step in evaluation of a thyroid nodule, a blood test, because that will tell us what picture we need to do next. If their blood test indicates hyperthyroidism, then you would proceed to the thyroid uptake and scan to help figure out why are they hyperthyroid. That nodule may have nothing whatsoever to do with their hyperthyroid status. So do that scan to see why they're hyperthyroid. Graves' disease, is that nodule hot or is it thyroiditis? Other than that, do not order that thyroid uptake and scan. It's a $3,000 test. Every ultrasound report from a lot of places says, consider doing thyroid uptake and scan if it has nodules. That does not make it the right test to do. So please don't order those unless they're hypothyroid. The thyroid ultrasound is the absolute best way to look at thyroid nodules. It can tell you if they are high risk, low risk, cystic, etc. And that is what's going to guide you on your next step, whether you need to biopsy or not. If the patient has compressive symptoms like that Pemberton sign with the guy with the arms up by his ears and his face gets red, it doesn't matter if there are nodules there or not. That person should have surgery to relieve the compressive symptoms. And then if there are suspicious lesions or large enough ones, you want to biopsy it. Try to get a sense of the nodules, whether they look benign, low risk, high risk, and direct your biopsies towards the suspicious ones, not just the big ones. And then if they're little or if they're biopsy proven to be benign, you can follow with ultrasound, but then mostly with palpation over time as they kind of prove themselves to be benign. And that's it. Any questions?
Thank you. That was wonderful. I think a lot of people enjoyed that, but I really enjoyed the examples and a lot of the screening tests and stuff. Does anybody have any questions?
Well, my question would just be, dealing with that report from radiology that says they need the other test. May we quote you?
Yes. And actually, it's in the guidelines. It says exactly what I said is in those American Thyroid Association guidelines that you only do that test if they're hyperthyroid.
Yeah, it just, it always looks a little iffy to, administrators and lawyers if we don't follow up on tests that have been recommended.
Yeah.
But I'm good. I'm glad to know where to find it.
Mm-hmm.
Perfect. Thank you. Any other questions? Any comments or anything that you guys want to discuss? Any patients? I know everybody's got a weird thing going on right now, but
The thyroid scans, those uptaken scans, they often show cold nodules, which makes people freak out, but that doesn't mean that it's cancer. And you can have a nodule that looks warm or hot that does have cancer in it. It's all just how the tissue overlies other tissue in the thyroid gland. So a cold nodule could have normal thyroid tissue over it and therefore look normal on the thyroid uptake. So that doesn't help you. And if it's cold, it could just be a cyst because that won't incorporate iodine, and that doesn't mean that it's a malignant thing either. So for those reasons and others, that's why that scan doesn't help answer the question of whether there's something suspicious in there or not, and shouldn't be used to guide whether you get a biopsy or not.
I have one other question, actually. Does the workup change if the person is on amiodarone when they develop the nodule?
The workup for the nodule itself does not change if they're on amiodarone. Their blood tests may look funny because they're on amiodarone. They could develop hypothyroidism or hyperthyroidism from the amiodarone. And if you feel a nodule, then, if it looks like, I would always still just do an ultrasound, because if their nodule looks like it has calcifications in it, I don't really care what medicines they're on or how their blood tests look, because even if they're hyperthyroid for no reason or from amiodarone, if I have an ultrasound showing that a nodule looks suspicious, I will still biopsy it to make sure there's no thyroid cancer in there.
Thank you.
Sure.
to the Endocrine Hub team, do you guys have any, just at this time, I know everybody's dealing with the COVID situation, do you guys have any recommendations for that, for patients trying to, I don't know, not make it in or anything?
For some of the just routine follow-up ultrasounds where we're just monitoring things over 6 and 12 months or even farther out, we're letting them delay and defer those ultrasound follow-ups again, because even if they have thyroid cancer, it's usually so indolent that a couple of months waiting, there's data to say that their prognosis does not change by having this, several months, even up to a year delay in evaluation or treatment. So let me think of anything else that's changed. Oh, we do have some people who, at least early on, were contacting us saying, who have thyroid cancer. I have cancer, therefore I'm somehow immunocompromised and at higher risk if I get, exposed to the virus. And the type of treatment for thyroid cancer has nothing to do with immune systems. I mean, the treatment is actually just iodine, radioactive iodine. And if it's anything beyond just surgery, it's just this radioactive iodine. So in fact, their immune system's not affected at all by having had thyroid cancer or for the treatment for thyroid cancer.
Perfect. That's very helpful. Thank you.
I have a question. I joined late. You might have addressed it.
Sure.
Okay. Now, is there any specific protocol for the like ultrasound follow-up of nodule? For example, like first we do in 3 months, then 6 months, then a year. I mean, this is the kind of pattern that I have seen with radiologists, but again, they vary.
Sure.
Okay. So if a nodule is unchanged, okay, what protocol we should follow, even if the radiologist didn't mention it?
Yeah. So again, very specifically, there are guidelines in the American Thyroid Association guidelines, but they're not going to cover every single scenario. So I'll tell you what I would normally do. So if it's an ultrasound, a nodule that I am aware of, either I felt it or they came to me because they wanted to have a nodule they knew about evaluated. If it looks like something that needed a biopsy and I have had a biopsy and it looked benign, then I would do an ultrasound again in 6 to 12 months. And then if that looked stable, I would wait double that time. So then I would go 1 to 2 years after that and make sure it's still stable. And if it's still stable after 2 years, I might say, okay, you can go 3 years now before you need an ultrasound. And I always follow that up with the caveat that if the person ever feels like it has changed in that interval when we aren't doing the ultrasound, we can do the ultrasound at any time. We don't have to ever wait a full year or have to ever wait 2 years just because that was the plan. So if I have a biopsy negative nodule, I would wait, depending on how suspicious it is, either 6 or 12 months from the first ultrasound and make sure it's stable. Then I would go 12 to 24 months after that to confirm that it's still stable, and then 24 to 36 months after that to confirm it's still stable. And then I probably would just tell them only come back if you notice changes. So that's how I would do it. Just stretch out the interval and let the patient know that if they are concerned in any way in between, just come back, we'll do the ultrasound anytime. Does that answer your question?
Yes, yes, thank you.
Sure.
Well, perfect. Are there any other questions or anything else you guys want to talk about in this forum? All right. So I don't want to keep you guys. You guys will get the slides and everything in the recap from today. If you guys have any questions, follow up, please let us know. We're obviously happy to send them out to Jessica and everybody to get them answered. Our next session is going to be on the 22nd, and I think, Jessica, I think you're handling it. It's hypoglycemia, is that right?
I think so.
Okay, perfect. That's what I've got. If you guys have any questions, if you guys have any cases, we are happy to help. Mitra and I both are happy to help submit those if that's a problem. And I believe that is it. So everybody have a wonderful day.
Thank you.
Thank you. And thank you, Jessica, for the excellent didactic. That was great.
No problem.
Perfect.